So we are going to go ahead and get started. My name is Elizabeth Aloni, and I'm with Schneps Media. Schneps Media is the largest local media company in the New York metro area. We publish over 70 newspapers, magazines, websites, webinars, and podcasts. And we do so throughout Queens, Brooklyn, the Bronx, Manhattan, Westchester, Long Island, the East End, and Philadelphia. Today, we're thrilled to bring you the webinar, Looking for a Long-Term Effective Weight Loss Solution. And today, we're excited to be able to introduce some extraordinary doctors. You know, many people are looking for a long-term effective weight loss solution. And today, we're going to discuss the importance of obtaining and maintaining a healthy weight and solutions when long-term weight loss has been elusive. I'm honored to introduce our panelists today. First, I want to welcome Stephen Marola Md, FACS. Dr. Merola is a board-certified, fellowship-trained surgeon specializing in minimally invasive general and bariatric surgery, as well as emergency and trauma surgery. He's the vice chairman of patient safety and quality and chief of general minimally invasive and bariatric surgery at NewYork-Presbyterian, Queens. He's also an assistant professor of clinical surgery at Weill, Cornell Medicine. Dr. Merola graduated from Franklin and Marshall College in 1991 with a BA in biology. He earned his medical degree at the Mount Sinai School of Medicine and went on to complete a 5-year general surgery residency at NYU Medical Center, Tisch Hospital, Bellevue Hospital, and the Manhattan VA Hospital. He then completed a 1-year fellowship in advanced laparoscopic and robotic surgery at Hackensack University Medical Center. Prior to joining NewYork-Presbyterian Queens, Dr. Merola was an attending surgeon at North Shore University Hospital, Long Island Jewish Medical Center, and St. Francis Hospital on Long Island. His current practice focuses on the use of laparoscopy in the performance of bariatric, foregut, gallbladder, solid organ, and hernia repairs. On staff at NewYork-Presbyterian Queens since 2002, Dr. Merola has assumed leadership and oversight responsibilities for many hospital areas related to quality, safety, and education. He directed the Surgery Fellowship Program and chairs the Surgical Peer Review Quality Assurance Community for over 10 years. In addition to his active clinical practice, Dr. Merola has published extensively in peer-reviewed journals such as Obesity, Surgery for Obesity and Related Diseases, Surgical Endoscopy, Robotic Surgeons Quarterly, and the Journal of the Society of Laparoscopic Surgeons. He's also co-authored a chapter on laparoscopic colectomy in the premiere of Robotic, Tele-Robotic Surgery. A lot to say, but impressive experience. Welcome, Dr. Merola. You're a little low. I couldn't hear you. Can you?
Thank you for having me.
There you go. There you go. We can hear you. Fantastic. Next, please welcome Joel A. Ricci-Gorbea. He MD and FACS. He is an assistant professor of clinical surgery at Weill Cornell Medicine and director of outpatient services at NewYork-Presbyterian Queens. Dr. Ricci is a board-certified, fellowship-trained general surgeon who specializes in weight loss surgery and hernia repair. He also specializes in minimally invasive surgeries and performs most procedures through small incisions using laparoscopy or the Da Vinci robotic platform. In addition to his clinical practice, Dr. Ricci is involved in research, resident education, as well as quality and patient initiatives. He is the co-author of several book chapters about disorders of metabolism and weight loss surgery and serves as a fellow of the American College of Surgeons and member of multiple surgical societies. Dr. Ricci earned his medical degree from Ponce School of Medicine in Puerto Rico. He completed his surgical residency training at SUNY Downstate Medical Center in Brooklyn and served his fellowship in minimally invasive and bariatric surgery at New-York-Presbyterian, Queens. Welcome, Dr. Ricci.
Thank you for having me.
Wonderful to have you here. So let's jump in and get started. Dr. Gorbea, what exactly is considered obesity and what are the associated health risks with it?
So obesity is excess body weight loss in a nutshell. Is when you have an excessive amount of weight over what is considered your ideal body weight. Associated health risks that come with it are multiple, what we call comorbidities, which are conditions that are associated directly to obesity. Namely, diabetes is one of the most feared ones. hypertension or high blood pressure, high cholesterol, and sleep apnea. Those are the four ones that are mostly considered associated to obesity. But in addition to that, there are several others, like polycystic ovarian syndrome, cardiac or heart disease, lung disease, asthma, obstructive lung disease, and kidney problems. So that's pretty much in a nutshell what obesity is and what conditions are associated to it.
Well, those are very severe conditions. So, Dr. Merola, what weight loss options are recommended with someone who has obesity?
I think once you're in that obese range, we'll talk a bit about that coming up. Usually typical, at least 30 pounds overweight. You know, many of the surgical patients, the criteria is going to go like 90 pounds overweight. You definitely need to lose the weight. There are not a lot of good non-surgical options in the sense that, you know, diets and all the fad things don't tend to work very well. The recidivism rate, the chance of regaining the weight after those diets is well over 95%. So in terms of what we can offer from a medical perspective that actually, you know, is effective and works, there's really two options. There's medical weight loss, you know, with an actual physician, and we have that in our practice now. And then for the more severe patients, there's clearly the surgical weight loss. And both of them have been proven to be very effective to lose weight in the short term, and more importantly, you know, maintain that weight loss.
Very nice that there are those options. And again, it's so critical because of the health risks that are associated with it.
Yeah, as Dr. Ricci mentioned, yes.
Yes. So what are the qualifications, Dr. Ricci, for weight loss surgery?
So the what we go about is what's called the body mass index, which is a measure of your weight versus your height, and it is predictive of how much weight you have over your ideal body weight. So on a 5'8" man, 5'8" tall man, the ideal body weight is probably about 165 pounds. If you weigh about 100 pounds over that, it usually puts you on a body mass index of about 40 kilograms per meter squared. That's usually the rule of thumb for body mass index, okay? And it varies for women and men based on their height and weight. So the qualifications are on any person with a body mass index of 40 without any associated conditions that I mentioned before, that usually qualifies you for surgery. If you have any of the associated conditions like diabetes, high blood pressure, high cholesterol, or sleep apnea, then a body mass index of 35 would qualify you for surgery.
Okay, that's very specific about that. Thank you. Dr. Merola, what are the benefits of weight loss surgery?
Well, you know, obesity in general, obviously, as everybody knows, causes a lot of health conditions. As we mentioned earlier, the diabetes, the blood pressure, sleep apnea, which is actually a very serious disorder to have. And all of this, unfortunately, does lead to a shortened life expectancy. Mm-hmm. So in studies dating back as 20 years ago, when they looked at, you know, severe obesity versus weight loss surgery, somebody who is severely obese and female probably loses a good 6, 7, 8 years of life. Men lose over a decade of life due to obesity. You know, again, we're talking severe obesity. You know, that body mass index Dr. Ricci talked about of over 40, which is about 100 pounds overweight, maybe 90 pounds overweight for a woman. So the benefit of the weight loss surgery clearly is to eliminate, get rid of, or hopefully even avoid developing those complications that shorten your life expectancy. So weight loss surgery actually has been shown to improve life expectancy, first and foremost, which is obviously, you know, what you care about. It also been shown to dramatically improve diabetes. Sleep apnea gets better after maybe even just 30 pounds in some patients in terms of weight loss. High blood pressure tends to improve. The other thing people don't realize is that obesity does have a role in development of cancers. So the reduction of weight also does reduce the risk of cancer. And more importantly, joint disease. You know, we see a lot of older patients in their 60s and 70s who, by the time they've been 60 or 70 and heavy for a few decades, are really having trouble with, you know, ambulation. You know, we live in New York City where, you know, people want to take the subway, take the stairs, things like that. So in all those ways, and in the end, it really just improves, you know, quality of life. So life expectancy, comorbidities reduce, and ultimately, you know, obviously improves your quality of life.
How two incredibly critical things, extending your life and extending and making the quality of your life better. You know, those are what we all wish for. So I've heard of gastric bypass and the sleeve. Can you talk to us about the difference between them? Maybe Dr. Merola, you want to get us started with that, and then Dr. Ricci, you can share more.
Sure. So they're the two most common procedures now in the United States, and the two that we offer in our program are sleeve gastrectomy and gastric bypass. In the Q&A, I guess, you know, people can ask questions about some of the other stuff they've heard about, like the bands and stuff that have kind of disappeared. But the two predominant operations are sleeve and bypass. The majority of patients nowadays do sleeve. The difference is basically is an anatomic one. The bypass, which I'll briefly mention first, is the older of the two procedures. It's created back in the 1960s, actually, when people realized that individuals who had gastrectomy or their stomach removed for cancer ended up being on the thinner side. So they started applying this to the severely obese patients as late in the 60s through open surgery. You know, we do it laparoscopically now, but that's how it started. And what that entails is dividing the stomach into two, one into a very upper, smaller, egg-sized piece of stomach, and then bypassing the remaining stomach. Due to the fact that we are bypassing the remaining stomach and dividing the two into two separate stomachs, we have to reconnect the upper stomach to your intestinal tract. We do that, and we kind of plug that stomach back into your GI tract, maybe a third of the way downstream. So basically, you get the small stomach, where most people get full on, say, you know, eating half a sandwich. And then on top of it, when you eat food, about a third of your intestines are not seeing either food or digested food. So you malabsorb a bit of the calories and fat, and that's how you lose weight with the gastric bypass. I don't know, do we have a picture of that or not?
You know what, let me see what I can pull up. I don't have it right now. Let me ask you something about that. So when you do the bypass, a part of the stomach then is not really used.
Correct.
Okay.
The bottom half, the bottom, actually, I will tell you, it's the bottom 90% of the stomach is not used. You end up, again, with the small little egg-sized stomach on top, which is reconnected to your intestines, and then the bottom part is bypassed. Common question is, well, you know, is that bad? What's the deal with that?
Yeah.
It's still making stomach acid. It does shrink, but it's no longer getting distended with food. It does create, still secrete stomach acid, which is needed for digestion. And it also joins up with the bile and some of the juice from your pancreas to create the digestive enzymes that will eventually meet up with the food and cause the digestion. But typically you eat, again, maybe half a sandwich, less than 1,000 calories, and you don't absorb everything you eat. So you lose weight in that way as well. Somebody had commented about an illustration would be helpful. We'll work on that. The second operation is a sleeve gastrectomy. It's also a very restrictive operation. Similarly, most patients, you know, get full on about a half a sandwich. A lot of patients like to describe it like a banana. So what happens with the stomach is we remove about 80% of the stomach, but all we do is just trim the stomach down to about 20% of its normal size. And as a consequence, food will go in that stomach, and just like with the bypass, you'll feel full. Unlike the bypass, we don't rearrange the intestines. We don't, you know, bypass your stomach or your intestines. So once the food does enter your stomach and leaves your stomach, you're fully absorbing, you know, the fat and the calories in that case. So you're not losing weight because of malabsorbing some calories. You're losing weight just from the restriction. Both operations do have a positive effect on your hunger hormone. It drops your hunger hormones a little bit, so people tend to be a little less hungry. In the sleeve gastrectomy, the part of stomach removed actually is the location of your hunger hormone. So patients after sleeve, but also after bypass, will have lower hunger hormones. And then lastly, the part of the stomach removed in the bypass also has some effect on glucose metabolism. So there's a positive effect on your blood sugar as well. And so both operations have a positive effect on lowering your blood sugar.
And what is the difference? Why would one person have the sleeve versus gastric bypass?
So I'll take that one. We use several factors to determine who will be served better by a sleeve or a bypass. Mainly, what we'll be using lately is the presence of diabetes, the use of insulin to lower your blood sugar, and the presence or absence of reflux disease, acid reflux. So in our algorithm in the practice, we usually use those two factors mostly for people that come in undecided on what surgery do they have. We allow the patient to decide what surgery they would like based on a video that we send them before visiting our office, where they get more information. And either if we agree or disagree, we give them our opinion, and together we make a decision on what surgery serves them best.
So that makes sense. It's important to speak with your doctor and go over what are the best.
Yeah, I always tell patients, basically, if they were to choose one operation we thought was not appropriate for them, I would let them know. But right. If both options are on the table, then our job is to educate the patient and help them as mutually come to a decision of whether they would prefer sleeve or bypass. And as Dr. Ricci said, there's factors related to either some would call reflux or diabetes, things like that may steer you toward one. One's a little bit riskier than the other, so but one loses a little bit more weight than the other. So, but these are all things we review in the office. And as I said, if one were bad for the patient, we say, look, you really don't want that operation. But if all things are equal, our goal is to really educate the patient to let them make the decision of what they think is best for them.
Absolutely. Let me share this picture.
Oh, great. So this is a bypass. I have to move my box so I can see it. So on the left is your normal stomach. So what you'll see is that top arrow is your esophagus, that narrow tube going into the body of the stomach. And then the other arrow in the bottom of the stomach is leaving your stomach. And then the rest of that is your intestines. So again, you have esophagus, the big thing with the hump is your stomach, and then off to the intestines. So as I mentioned with the bypass, we divide it into two stomachs. We have that upper stomach, which is like, basically, it's not quite the scale, but about the size of an egg. And then you see that there's a bypass stomach. What this arrow is showing you is food's going from your esophagus, then through your new small pouch, and again, it's referred to as the pouch, and then the food goes off the intestines. The reason you lose weight is the food coming down that track there hasn't seen your digestive juices, because your digestive juices are actually in the distal stomach and that first part of your intestines. That's where your liver and pancreas plug in. So until they meet in that common channel down below at the very bottom right, the food's not digested. You need to digest food to absorb it. So when the two meet, digestion will occur. And then for the last 2/3 of your intestines, you absorb the fat, the calories, the nutrients you need. So you lose weight, again, because you're eating smaller portions. And then no food's going through the stomach portion, no digestive food's going through that first portion. And when they meet up, that's when digestion occurs. And that's when you start to absorb the nutrients that you need. So it's a combination of restriction and a little combination of malabsorbing.
Terrific. Thank you for that explanation. I also have another picture here that I can share.
That'll be the sleeve, I'm guessing. So similarly, if this is a sleeve, basically what Dr. Ricci and I do is we start near that pyloric valve in the bottom. We go about, technical reasons, we do 8 centimeters back from that, and we cut from there all the way to the top. So that portion on the right actually gets removed. We take it out. It leaves about, it's not quite the scale, but for a distended stomach, you're losing about 80% of the stomach. What remains actually is a tube, looks like a banana, that doesn't really distend very much. The normal stomach out on that right side will distend a lot. Once you remove that and replace it with that staple line, it doesn't distend very much. So you've got a banana-shaped stomach. It's almost the size of a banana. Doesn't really distend very much. And again, just like with the bypass, most patients, if I gave them 2 slices of bread, 2 slices of turkey, and a slice of cheese and said, eat the sandwich, most people would get full on half a sandwich and they would be satisfied. And again, that upper right hump where you see it comes off, that's where I mentioned earlier. That's where the hunger hormones live and glucose metabolism also begins. So it has a positive effect on both by removing it.
Terrific. Thank you so much for walking us through that. So after surgery, what is, Dr. Ricci, perhaps you can answer this, how much weight loss is expected?
So it varies from both operations, not by much, but from the bypass on the sleeve, you're expected to lose about 50 to 60% of your excess body weight. That means if you're 100 pounds overweight, you will lose about 50 to 60 pounds of those 100 pounds. That's what's expected from the surgery. Some people go over, some people go less, but that's usually the average. For the bypass, it's a little bit higher because of the malabsorption that Dr. Merola was mentioning. So the bypass, you're expected to lose about 60 to 70% of your excess body weight. So, that happens within the span of a year to 2 years. That's usually the window that we give the patients to allow healthy maximum weight loss. Obviously, with the guidance of our team, our nutritionists, our nurse practitioner, follow-ups, seminars, post-operative classes, and especially visits to our office, because it's easy for the patients to fall off track and go back to behaviors that might lead them to gain weight. So we try to keep them on track with follow-up visits.
Wow, that's a really important thing. So there's a whole team post-surgery that supports a patient in all these different factors. So it's not just having the surgery and be done, but there's all this other support afterwards.
Correct.
So is this weight loss permanent?
It is not guaranteed to be permanent. It is purposely done this way to be maintained, but the patients have to put a little bit of work to be able to maintain that weight off. So the surgery is not a guarantee. The surgery, we always tell our patients, the surgery is a tool that, along with all the other components of their lifestyle changes and our team support, they will be able to achieve a healthy maximum weight loss within the span of a year or two, and then maintain it for the rest of their life. That's the goal. I always tell our patients, you're going to be my patient for life. Nice. Whether they do it or not is up to them, but that's usually what is taught and what is recommended, because there's no guarantee, and there is a percentage of patients that can gain the weight back if they fall back to old habits and they start eating unhealthy. But for the most part, they can maintain the weight loss if they follow our guidance and our recommendations.
And I'll comment that there's definitely literature and support that shows that long-term follow-up is usually the most successful patient. I think it's kind of makes sense when you say it out loud, but basically, if you don't come back and get checked on, who's holding you accountable? If you have the surgery and you don't see anybody who knows you had the surgery, nobody's going to track your weight. But as you mentioned, we have a very supportive program. We have a dietitian, we have a nurse practitioner, we have support groups, and we'll talk about that later. But I think I always tell patients, if you're coming to the office maybe twice a year for the rest of your life, basically to get weighed, you're coming to support groups. We have 11 a year. Come to those. You come back and see our dietitian. Every other month almost, you're seeing somebody who knows you had surgery. And studies show that the patients who follow up long term are the ones that really don't come back with weight gain, because you gain 3 pounds and go, okay, next month I have to see the dietitian at Dr. Ricci and Merola's office. I'm going to buckle down. But if you don't see anybody for 4 years and know you had surgery, the weight starts to creep up. And so, as Dr. Ricci said, it's a tool. You need to eat healthier, got a little bit of exercise, but coupled with a tool, a sleeve or a bypass, you'll lose a lot of weight short term. But more importantly, with that long-term follow-up, you'll keep it off.
That's really important to drive home to everyone, that it's important for you to follow up and make sure that you keep this healthy lifestyle and get all the benefits that you can have. So is this weight loss surgery covered by insurance?
Yes, for the most part. Most insurances do cover weight loss surgery as long as you meet the criteria that Dr. Ricci mentioned earlier. So for most insurance companies, you have to have BMI, at least 40, or that body mass index of 35, and you can calculate that. You can Google a BMI calculator and figure out what your BMI is. So if it's over 40 or 35 with complications like diabetes, sleep apnea, or hypertension, most insurances will cover it. We do recommend that everybody check with their insurance and call and ask. There are other requirements, for example, nutrition evaluations, and there's a psychiatric evaluation required by most insurances, and a period of counseling with a lot of insurances. There are a few insurances, depending on your employer, that have opted not to take bariatric coverage. It doesn't happen frequently, but it does happen. That's why it's important, both from our end and also from the patient's end, since you're the customer, to verify that you have it. But for more and large, it's surprising when somebody doesn't have coverage, at least in New York State.
Okay, so that's good to know. And that's
if they meet the criteria.
And that's something that can be discussed at the offices when you come and meet, to be able to make sure and to call
Yes, and we do so much. We've done so many surgeries with so many different insurers that we kind of have an idea. There's that rare exception where within a certain employer's insurance, they might not have taken the additional coverage for the bariatric. But that's pretty rare. It happens on a rare occasion. But that's the importance of verifying, because it kind of stinks to go through the whole process and at the end realize that you don't have the coverage with your insurance.
Absolutely.
So the bottom line is that we figure that out when you come in, and most insurers do cover bariatric surgery.
Terrific. So you had mentioned a little bit about laparoscopic. So how are these surgeries performed, Dr. Merola? Are they all laparoscopic? Are some of it open?
It's rare that we do anything open. It's almost all laparoscopic, both the gastric bypass and the gastric sleeve. For somebody who's never had any prior, significant upper abdominal surgery, which is the majority of patients, haven't had prior bariatric surgery or haven't had some kind of, stomach surgery before. I can't remember when we haven't, gone laparoscopically. I will say whenever we do an operation laparoscopical, we always, say, we can't do it laparoscopical, we'll have to do it open. But even that, I don't remember the last time Dr. Ricci and I have converted to an open procedure. I think the only ones that might end up with open might be somebody who's had prior surgery in the upper abdomen and the stomach area, not just the stomach itself. Those, can be a little bit trickier. But the majority of patients coming in, that we see have never had any, upper intestinal surgery, and for them, it's laparoscopic.
Fantastic. So, Dr. Ricci, how long will one be in the hospital after this laparoscopic surgery?
It's usually a 23-hour stay. They usually go home the next morning.
Wow.
Before 11 o'clock, around noon. Some people might stay an extra day if they have other conditions that are associated and they're a little bit sicker. But for the most part, I would say 99% of our patients goes home the next morning.
That's
so it's just an overnight stay. Sometimes for the bypass, they'll stay an extra night, but usually they go home.
That's extraordinary. So what is the recovery like then? How long should someone expect to be out of work or not taking regular activities?
So it's usually about anywhere from 2 weeks to a month is the usual for our patients to stay off of work. And it's mostly because at the beginning, you can't drink that much water. So the fear is that you might get dehydrated. So you might feel a little weak for the first couple of weeks. But pain control is very well taken care of by the medications that we give them, both during the surgery and after. But it's, for the most part, it's just getting used to the diet, getting used to having a little bit less energy for the first couple of weeks from the trauma from the surgery, plus the lower caloric intake. It usually takes the patients about 3 weeks to a month to go back to work.
Got it. Thank you. Dr. Merola, if I've decided I'm going to move forward with the surgery, how many office appointments are associated? What should I expect?
That's a fair number. It's somewhat of an involved process. As far as requirements, as far as visits, for example, the initial visit, you come see Dr. Ricci or I. We do give you a video presentation, that either we send it to you ahead of time or on iPad to give you kind of pre-op education. Everything we're going to give you is also going to be in writing. So you'll see us initially. At that visit, we'll discuss, your health, the benefits of surgery, the risks of surgery, the 2 operations, and go from there. As far as what's, required and appointment-wise, most insurance carriers in New York do require some form of weight loss counseling required ahead of time. Many are 6 months, so it means you have to see your physician once a month for 6 consecutive months to lose weight. And some don't. Again, we work with a lot of insurance, so when you come in, we can kind of figure out what your requirements are. In addition, they all require a nutrition evaluation. We have a very good nutritionist in our program who, you would get an appointment to see as well to meet that requirement. And again, obviously, more importantly, for that education you need to get the best result from your surgery. There's a psychiatric requirement by most insurers. There's about 3 mental health providers that we've been using. And I always tell people it's not because we think you're crazy. It's required by insurance, but it's also a life-changing operation. It's changing your health, your relationship with food, your appearance. It's worth talking it out with somebody for an hour. So those are the big, ones for the insurance companies. In addition, they want obviously our documentation, and that's kind of the requirement for insurance. From a medical perspective, to make sure we're doing this safely, though, there are other appointments. Usually, we do want a cardiac evaluation, make sure you don't have any coronary disease. There's a pulmonary assessment, usually because the weight does restrict your breathing a little bit, and also to assess to see whether there's a chance that you have sleep apnea. And then finally, an endoscopy. We've done in our patients routine preoperative endoscopy to assess the esophagus and for H. pylori bacteria and a number of other things before we go on to divide the stomach either through a bypass or a sleeve. So in summary, I would say it's the counseling with the medical weight loss counseling that many insurers require, a nutritionist, a psychiatrist, and then the medical stuff is the cardiac and pulmonary and GI. And as far as your question of visits, I actually calculated it. Just in our office, it's about 5 in the sense that you'll see the surgeon at least twice. You'll probably see our nurse practitioner, for a follow-up at some point during the middle of the process. You'll usually see our dietitian at least twice before surgery. And then again, as I mentioned earlier, there's follow-up, a lot of follow-up afterwards with us and our NP and with our dietitian as well.
As they say, it takes a village, but they certainly you certainly though make sure that a patient is this is safe and that you're going through every single step to make sure. And it sounds like there's a lot of hand holding through those steps, letting people have the right nutritionist and psychologist and meeting with their doctor on a regular basis so that they can feel comfortable and know that this is under the safest of circumstances.
And we also, besides obviously spelling all this out, we have navigators, Dr. Ricci and I. We have 2 navigators in our program who are there to kind of help you, whether it's to make sure documents come in or if you kind of get lost in the process, what should I do next? So you have access to those people to help navigate and ask questions to.
Oh, wonderful, wonderful. So, Dr. Ricci, are diet and lifestyle changes required before and after surgery? I know we talked a little bit about that, but could you dig a little deeper into it?
Yes, so definitely diet and lifestyle changes are one of the most important things to add to the surgery. We always recommend the patients to start the new changes in their lifestyle, healthy grocery shopping, healthy eating, eating how many times a day, depending on what our registered dietitian tells them. Because that, alongside with the surgery and an exercise regime that allows them to burn fat at the same time that they are eating healthy, it's these 3 components of weight loss. So like I said, the surgery is an important part of it, but I will always tell my patients, this is about 30% what we can do for you and 70% what you can do for yourself. It's not a 50-50 partnership because the surgery is only about 1/3 of the components, and the other 2/3 are up to the patient to change and incorporate, mainly the exercise and the healthy eating.
Very, very important distinction. Dr. Merola, how are patients educated on this surgical process and the diets they're supposed to follow? I know you talked about these different specialists that you bring on board. How does that work? Are these all in person, or are they, you mentioned some things are written down and these individuals that help navigate?
Yeah, I mean, I think the process is educate is I always tell people it's quite incredible actually compared to most other surgery. If you needed like a hernia repair or your gallbladder removed or even a hip replacement to some degree, I think you're not getting videos, you're not getting navigators, you're not getting a whole process. The whole process, as I said, starts with that office visit, with the educational video that we provide that our dietitian's on and our nurse practitioner, Dr. Ricci, and I, and so it's kind of introduced you to the program. When you come in, you get besides obviously speaking with one of the 2 surgeons, one-on-one for the initial consultation, you get a pamphlet, a big folder with everything summarized in writing. As I mentioned earlier, you're getting at least 5 visits preoperatively with somebody in our office, a clinician in our office. Again, there is the navigator to help educate you as well. And then the one thing I didn't mention earlier is we actually do a Zoom class once a month, which is further education that we do through our program to kind of give you a bit more detail about the surgery and the hospitalization and the expectations. And so we usually ask people to sign up for at least one of those Zoom classes, in the months before they come in for surgery, basically. And as far as diets, our diet program has been, written by our dietitian, Mian Condi. You'll meet with her at least twice, as I said. She'll go through the diets with you. And again, she's going to be a very important resource, on the other end, once you've had the surgery to maintain and get the best result possible. So there's a lot of education, a lot of people.
I mean, it sounds wonderful to me. It sounds like, you know what? It's an opportunity to get pampered. You know, when is the last time people get taken care of so well?
I think there's a lot of visits, a lot of people that you're going to interact with, which hopefully will promote, and in the middle of all that, there's an operation actually. But that combination we find works, really well for, obviously doing the surgery safely, but more importantly, getting that, that optimal outcome afterwards.
Yeah, really speaks to the change in your quality of life. And all of these people are caring about your quality of life and focusing on that. And I think for most folks, we're so busy doing and being and caring for others, we don't have that for ourselves. And what a great gift it is to be able to give yourself better health and have all these individuals come together and do that. So speaking about, caring for oneself, what about support groups? Dr. Ricci, are they offered after surgery?
Absolutely. So like Dr. Merola said, we actually have a Zoom class every month. We have support groups in both English and Spanish. So I'm native Spanish speaking. So for the Spanish speaking patients, I usually tell them if they want a Spanish speaking doctor, they can speak to me. But yes, we do have support groups. We have seminars. We have preoperative classes. We have chats that we recommend. And there's all sorts of chats that are approved by medical societies online that the patients can also access. There are going to be people that are going through the same struggles as they are. And I always tell them, this is something that you can share with other people, see what they're doing. We can tell you what to do better. So that's why it's important to follow up with us, because we will give them all of those tools and all of those all of that access to us and other patients.
I think some people might be surprised about the need for a support group. Dr. Merola, can you talk about why it's important to have support groups around this?
I think that, as I said earlier, part of it is just staying motivated. This is a lifelong commitment. I always tell people the stuff we talked about earlier actually is to some degree the easier part. The hard part is you got to maintain this. Patients, the average age of people having surgery, I mean, it ranges from, in our practice, 18 to 70 plus. But if you're in that middle ground or in that young ground or even older ground, I mean, year one, you're going to be motivated. You're not going to eat anything bad because you're going to feel bad. You're going to feel guilty. But if you have another 10, 20, or a 20-year-old have 60 years of life, year one is the easier year. But but year 5, year 10, year 12 out, you have to maintain that healthy habit. So support groups work in the sense that you're coming in for a couple of reasons. One is that they're given with a topic in mind usually, so you learn a little bit. And then secondly, you're talking to other people, and learning about their struggles as well to kind of keep you motivated, so that you don't have that that weight regain that that can happen in about 10 or 20% of people. And the nice thing about our support group, since the one maybe positive coming out of COVID, was we started doing them as a Zoom. It really helped attendance because it's much easier to do a Zoom support group than say leave work, drive over to Fresh Meadows, park your car, spend an hour in a session, but it always goes a little bit longer by the time people mill around afterwards and then get home at 9 o'clock at night. Now you pop on the Zoom, and then an hour later you're off the Zoom. So it's gotten very popular, and our intent is actually, even if restrictions get even further lifted, that we'll continue doing them as a Zoom. So again, it's a nice resource that once a month you can get on your phone and meet the other patients who've had surgery and meet with our dietitian.
That's fantastic that it's so easy to do. So I'd like each of you, maybe Dr. Merola, you can get us started with it, and Dr. Ricci after that. Talk to me about what's unique about the NewYork-Presbyterian Queens program for bariatrics.
I think that, again, I kind of alluded to earlier how comprehensive it is, but also we've been doing this a long time. It probably is the oldest, bariatric program in Queens. Started, when I joined in 2002, for over 19 years, 19 years, I think this year. I think that there's a team, there's outcomes, and there's great support. I think from a team perspective, there's Dr. Ricci and myself combined. We've been doing this for 30 years now. So we've seen a lot, and we have a lot of experience. Again, we have an excellent dietitian who's been doing it for many, many years. We have a great support staff. You know, you mentioned the coordinators, our navigators, our front desk staff. You know, we have a comprehensive center in Fresh Meadows where basically all that's on one floor in Fresh Meadows. In addition, it is one location. You know, everything basically, you know, you don't have to go to 8 different places to see us. In addition, outcome-wise, you know, very safe. Weight loss surgery has gotten to the point where it's almost as safe as taking out, you know, somebody's gallbladder. And we've had really, you know, knock on wood, you know, very little, you know, complications over the last, you know, decade, and even over the 20 years we've been doing it. And then support-wise, as I said, from the uniqueness, you know, we have the navigator, we have the educational classes, we have the Zoom support groups, you know, we have the single location. So, you know, I think that, you know, we cover all our bases basically, you know, very well. And we've been doing it a long time. So we you know, we have a lot of experience.
Very important. Dr. Ricci, what would you like to add to that?
I think the most important thing is that you have everything in Queens. It's, you know, we are very proud to say that, you know, Queens is a big borough in the city, and it's very diverse, and it's not as easy to get around in New York City when you have many hospital options, many places where you can go. Here in Queens, we keep everything kind of like in-house.
Mm-hmm.
And I think the access to the patients, the support group, the team that Dr. Merola mentioned, you know, we cover all our bases. We just added a medical doctor who's a weight loss specialist, who is going to help the patients that don't necessarily qualify, or maybe they have to lose some weight prior to surgery, or they even have surgery before and they are not candidates for revision. You know, maybe they can go to a weight loss specialist who's a medical doctor, and it's going to clinically supervise you to lose weight along with the guidance of a dietitian. So that, you know, in it by itself is a must-have that not a lot of other programs have. We have 2 experienced surgeons. We have a very good registered dietitian, and we have people that care a lot about the patients. So I think in it by itself, that speaks a lot about our program, and we're very proud of it.
Fantastic. And look, you're here now, today, sharing with all of our attendees all this important information. And that speaks a lot, you know, that your commitment to patient satisfaction and success and happiness and safety, all of that commitment, you know, shines through here today, and the fact that you're here today. And I so appreciate both of your being here. We do have some questions from our attendees, and I'd like to get to some of those. So the first question I'm going to say is, Kim wants to know, what is the difference between medical weight loss and surgical weight loss?
Since I brought that up earlier, I'll take that. So, you know, because I think we didn't have time to delve into that. So medical weight loss and surgical weight loss differ. That medical weight loss is non-surgical, you know, so there are options for non-surgical weight loss. Typically, there are medical specialists who, as Dr. Ricci was alluding to earlier, you know, who treat obesity with behavioral therapy and also with pharmacotherapy. If you watch the commercials on TV about a lot of the diabetes drugs, we'll mention, oh, by the way, you know, you might lose some weight with it. So those drugs are approved by the FDA for diabetes, but off-label, a lot of what we call bariatricians, which is a fancy word for, you know, weight loss specialists, are using them, you know, off-label for weight loss, and they work quite well, like Victoza, something called Saxenda, things like that. So we have that opportunity in our office. You know, he's an endocrinologist who joined us recently. We've been using him mostly, as I think Dr. Ricci alluded to. We're using it for patients who, you know, may have had a little bit of weight gain, haven't followed up in years and gained some weight, but have a fully functioning surgery. They still can't eat very much. It's just that, you know, they may have slipped in, you know, diet-wise. You know, that might be the perfect candidate to see a weight loss specialist to lose weight. We also have some patients that are very heavy. You know, once you're, you know, 450, 500 pounds, you're a higher risk candidate. So we'll try and get them to lose some weight preoperatively, maybe with a weight loss specialist. And then the other subset is for the patients who either are not eligible for surgical weight loss because they don't meet the numbers, you know, the BMI over 40 or that 35 plus. Let's say your BMI is 36 and you don't have any complications, you're not eligible for weight loss surgery, but you're still 70 pounds overweight, you know, and it may, you know, eventually impact your health. So that might be an option for a weight loss specialist. Or a patient who has the BMI over 40 but isn't really ready to commit to, you know, a weight loss operation yet. I will say for our program, we're expanding that, you know, slowly over time. Once we brought the weight loss specialist on board, he got extremely popular. And the reason is, I can give a whole other talk on that, but the reason that it's popular is there's not a lot of good options for non-surgical weight loss in Queens. I always tell people, you go to your medical doctor, they say you're overweight or you're obese, you need to lose weight, and they say, I'll see you in 6 months. And they don't tell you what to do. So they don't. They say you're 30 pounds, so you got 40 pounds to lose, and then, eat less carbs and come back in 6 months. But there aren't very many doctors who actually specialize in weight loss. So again, that's what this endocrinologist does and what we brought into our program. Again, we're ramping them up, for non-surgical weight loss for patients who, don't meet criteria. We're using them a lot. Dr. Ricci and I have been utilizing them a fair number, and we're hoping to expand his services. And so the long answer to the question of medical versus surgical is, obviously we spent the last, whatever it's been, 45 minutes talking about surgery and surgical weight loss. The question about what medical weight loss is, it's really pharmacologic and behavioral therapy, but with somebody who's trained in this. The person we're using, actually, there's not a board in obesity medicine, but there's an added qualification examination and in education for that. And he's actually passed the qualification. He has an added qualification as an obesity medicine specialist. And he is the kind of person willing to prescribe pharmacotherapy, because a lot of even internists out there, although they know the drugs are out there, are nervous about prescribing them because they don't know the side effects. But that's what a weight loss specialist, and that's what medical weight loss is.
Got it. You mentioned something I just wanted to clarify, because I was wondering, when you say that that you have to have a 35 if you have certain complications, or 40 BMI to be able to have the surgery, you're not just talking about from an insurance perspective. Are you just talking about from an insurance perspective, or are you saying, just medically you don't do the surgery for people?
It's a good question. So it's both. So it was based on a decision made back in 1991 that hasn't been updated in 30 years. But the reason I came up with those numbers is basically, I always tell people, everything you're doing and everything Dr. Ricci and I do as surgeons is a risk-benefit analysis. What's the risk versus what's the benefit? I always tell people it's kind of like when you cross the street and your car is coming and you're making a risk-benefit of, should I let the car pass? Or should I go across? Well, I hope I don't get hit. And obviously, you think you're going to get hit, you're going to wait for the car to pass. So surgery, what we do, that's how I look at it as a surgeon. I do the same thing as a surgeon. So the numbers that came up with were based on a criteria from the National Institute of Health in Washington in 1991. The thought was that if your BMI was over 40, that you were safer having surgery than living with a BMI over 40. That there was more benefit, even though surgery is scary and there's risk involved, your risk was less having surgery than living with that BMI over 40. So that's how they came up with that number. And also, again, if your BMI is 35 and you're diabetic, the thought was, well, you know what? Having BMI 37 and diabetes is far riskier than the operation. You should have surgery. That's what they set up in 1991 as the medical indications. The insurance companies adopted the same numbers. Honestly, the numbers should be lower, because the operation they used for that risk analysis was an open gastric bypass, which is very risky. The surgeries these days, as I said earlier, have gotten to the point where they're as safe as, as almost as safe as, if not as safe as gallbladder surgery. So therefore, those numbers should come down a bit. And I really think it should be 35 with no complications, or 30, with a complication. But we can't get them down lower because of the insurance companies. Because then if you lower those, you lower those numbers, then many more people are eligible for surgery. So
what do we do? Do we write to our congressman? Like who?
I think that the insurance companies have much stronger lobbyists than the patients and the surgeons. So, and the last thing I'll say about that is that the risk of surgery is always going to seem scarier, because you're bundling all the risk of operation and you're facing it head on one day, the day you have an operation. Your obesity, although I'm telling you it's greater if your BMI is over 40 or 35 with complications, that your obesity is much more dangerous than the surgery. Surgery is always scarier, because the risk of the obesity is not going to catch up to you in a day or 2 or 5 or a year or 5 years. But 10 or 15 years down the road, you could have coronary disease and have stents and issues and clearly like, oh, I wish I had lost the weight 15 years ago. But surgery is always going to be scarier. But again, those numbers are based on medical and insurance, as I said, but medically it's felt to be beneficial with those numbers.
Great, thank you so much for that clarification. Suzette has a question. She said, I'm diabetic, I'm 44 years old, I weigh 274 pounds, and I'm thinking about doing weight loss surgery, and I'm scared, as we were just talking about, from dying from an infection. So, what what would you be, what would be your advice to someone like that who, you know, we were just talking about, you know, the fear of the surgery?
The complication rates are less than 1% across the board. And so 1 out of every 100 patients will have some complication. You know, and the most feared ones are related to a potential infection from a leak from the area that we cut the stomach off, or where we connect the stomach to the intestinal tract. And that happens less than 1% of the time. And our practice numbers correlate with the national numbers. So, you know, we always tell the patient, yes, there's a risk of having a complication, but we give you all the access that we can give you to access us 24/7 when you have symptoms at home, and we know how to take care of those complications to the point where the patients are not affected long-term by them. So yes, there is a risk. The risk is very minimal. We take all of the precautions during the surgery, after the surgery, with the instruments that we use. We actually assist each other when we do complicated or higher risk cases or complicated cases. So you have 2 experienced surgeons doing the surgery for you in certain cases, especially the bypasses and the sleeves on the super obese patients. So, you know, we keep that to a minimum. It's a fear that it is present, like with any other surgery, you can have complications, but we have been very not lucky, but very blessed to have very low amount of complications and a lot of experience together.
And it's because of the experienced doctors that you have and the team that you have in place, and, you know, all of the learnings, I would imagine, from all of this experience.
Yes.
And as Dr. Merola was saying too, you know, I thought that was a good point. You know, there's a bigger risk of not having the surgery and living with that level of obesity. We have another question. Can any of these surgeries be reversed after a period of time?
So, I mean, there's really no reason to reverse them. So a sleeve gastrectomy, the answer is going to be no. Because if you remember from the diagram I showed earlier, that piece on the right side that says resected is literally resected. It's removed. So you're left with just that tube. There's really no reason to reverse a sleeve gastrectomy. You know, the most common problem you're going to have after that might be, you know, that 10 or 20% of people with you know, weight gain, you know, after surgery. So that's not a reason to reverse it. That's a reason to follow up this frequently and maybe use the weight loss doctor and, you know, and improve your habits. As far as bypass surgery, it's basically, I've never seen reversal. Theoretically, you could undo that operation and re-put it back together again. I don't see a reason that would be done. Some people, it's described in some theories where people have done it because they've had pain and things like that, but I've never personally seen, I don't know if Dr. Ricci's ever seen anybody or know people reversing bypasses. Again, the most common problem you're going to have is maybe gaining weight back, but that's not a reason to reverse the procedure. That's, you know, a reason to either, you know, work on your diet, work on the bariatrician, or, you know, talk about, you know, revisional options for certain procedures.
Thank you. Another question came in. Are there any weight loss surgeries for people with BMIs between 30 and 35?
Mm-hmm.
So those options, and that's what Dr. Merola was alluding to before. We wish that the numbers are scaled down by the associations and the insurance companies. Those patients that have BMI 30 to 35, there's some limited options for surgery. There's nothing that is FDA approved that we would recommend. Those patients, we usually recommend medically supervised weight loss, and they fall into the category that we would send to the medical weight loss specialist or to our dietitian. I would never advise a patient to gain weight to qualify for surgery. That's not what we do. That's not something that we advocate. We always advocate to try to lose weight on their own with a healthy diet and exercise regime. And the surgery would be an option if that eventually fails. But not, you know, I wouldn't advise a patient to try to gain weight to qualify for the surgery. That's not in our repertoire.
Got it. We also have a question about loose skin after surgery. Does that happen with loose skin? And, what can one do about that?
So there is going to be loose skin. It varies from patient to patient. It all depends on years that they have dealt with obesity, how much weight they have over their ideal body weight, their body habitus, if it's more distributed to the trunk, the arms or legs. So all of those factors contribute to how much skin they're going to have, quote unquote, loose after the surgery, but it will happen. There is skin reduction surgery. There is exercises that are targeted towards improving muscle mass or increasing muscle mass and toning prior to having the skin reduction. What we usually tell the patients is to wait at least a couple years after the initial operation to assess the loosen or the excess skin, because you want to maximize the amount of weight that the patient loses prior to removing some of those skin. We also tell the patients to try not to get pregnant within 18 months to 2 years after surgery, namely because of the hormonal changes that happen after the operation. Also because when you lose that immediate weight that comes off, if you get pregnant after that, the baby weight is going to probably interfere with the overall weight loss that you need to achieve. So if you do that prior to 18 months, you haven't maximized the amount of weight that you have lost, then you get pregnant, it might stall the weight loss. And also the caloric intake that you need to keep the baby healthy throughout the pregnancy is going to be affected by the fact that you cannot eat as much. So all of those things together, we tell the patient that's a very important thing that the patient should know, especially during the reproductive years.
Thank you for letting me know that. So, I could spend the whole morning talking with both of you, but I'm sure you have a lot of other things to do too. Before we go though, I would like each one of you just to give me a little jewel of, if you were talking to your best friend, your family, what would be your advice around weight loss surgery? You want to kick that off, Dr. Ricci?
So, for me, it actually hits a little harder. My dad used to be a diabetic for about 35 years, and he ended up in dialysis. He ended up with many coronary stents in his heart, and he ended up dying of complications from diabetes. And if he would have targeted weight loss at an early age, he would have probably decreased the complications, and he would have lived longer, to see his grandkids and be with us now. And so I always tell my patients, the ones that remind me of my dad, I always tell them that. I always tell them, listen, this, I can tell you from experience that this works. I always treat the patients like they're my family members, and I will never tell them have surgery if it's not the right thing for them to do. And that's usually my algorithm to treat the patients that come to my office.
Beautiful. That's a very powerful story you shared. Thank you for sharing that. Dr. Merola?
I would echo that, and I would say that, as far as coming for weight loss surgery, it's got obviously something you have to kind of, come to terms with and say, look, you're ready for that next step. Not everybody is. We have patients who come see us for an initial consultation, and then I might not see them again for, 2-3 years, because they finally come back and say, you know what, I started 2-3 years ago. I thought I'd give it one more shot. It didn't work. I like to think that some of those patients who I saw 2-3 years ago never came back because maybe they succeeded. But when they come back, I think that at that point they're ready. And I think you just have to decide if you're at that point. I think that if you're even a little bit curious, the last thing I want to stress is that I always tell people that visiting us is really, it's just a consultation. We're not, signing you up or doing surgery in the exam room down the hall. It's, as I mentioned, many people, it's a 6-month process at least to get close to surgery. So, if you want to learn more, you come in, you meet with Dr. Ricci and I when we go through the whole process for you. And I'm not offended if you come in and say, you know what, I'm not ready for this, and I'm going to keep trying, and I'll come. And it was nice meeting you, and I'll come back if I need you down the road. I think that's totally fine if you just want to learn more.
That's great advice. And I did just share the phone number. People can reach out. It's 718-445-0220. So you can call that number and you can learn more about treatment options. And like, Dr. Merola said, make an appointment, have a conversation. You're here today, so you have an interest in it. and it's step one. Take step two and make an appointment and find out, because to me, it sounds like from what you've all shared, the benefits of weight loss this way and being able to live a healthier life and a longer life are incredibly valuable things. And here's an opportunity to do something about it.
Coming to see us, you're not making any commitment. And, I think coming to see us is a little scary because we are surgeons, and Dr. Ricci and I have been using knives this week. So it takes some courage to come see a surgeon. So again, I want people to understand it's really not don't feel committed like you have to come in and say, okay, I want to have surgery. Just come in if you want to learn more. We're happy to spend the time with you and educate. And
everyone got a chance to meet both of you and realize you're not scary, and you're very warm, wonderful gentlemen. And
it's hard on the Zoom to come across that way, but we're both friendly and we don't bite. And I think if you want to learn, more, it's the best way to do it is to come in. And as I said, you're not committing to signing up for an operation. You may we're totally both fine if you walk out and say, you know what, I've learned a lot, but this isn't right for me. Or if you say, oh, you know what, I think that it's time, then obviously we have a process we'll help put you through, and the whole team.
Fantastic. So take that step. I say a journey of 1,000 leagues begins with a single step. So here's the step, make the phone call. Thank you all for being here. Dr. Ricci, Dr. Merola, again, thank you so much for your generosity with your time and your expertise. I truly appreciate it. I want to thank all of our attendees for joining us this morning. We will send you, as I promised, we'll send you the link to this so you can see the recording and you can share it with individuals. I will also be sending the contact information via email tomorrow, so you'll get all of that as well. And I hope you all enjoyed this important information. I wish you all a wonderful day. Please stay safe, stay healthy, and we'll look forward to seeing you on a future webinar. Bye, everyone.
Thank you very much.